Thank you so much, Dr. Muehlbach, for that insightful presentation and giving us a good feel for what the literature says. Now I am happy to introduce Barry Krakow, MD, who started in sleep research in 1988 and helped pioneer innovative therapies for chronic nightmares. Since 1995, he has practiced sleep medicine full-time and operates My Mind at Ease Sleep Arts and Sciences, a private center specializing in the treatment of sleep disorders in mental health patients within the framework of the mind-body-sleep dynamic therapy model. He's principal investigator of the Sleep and Human Health Institute, a nonprofit research facility that has published peer-reviewed papers on the PAP, the high prevalence of sleep-disordered breathing in chronic insomnia, and on the use of in-lab manual titration techniques for advanced PAP modes in CPAP failure cases, most notably PTSD patients, chronic complex insomnia patients, and other treatment-resistant OSA UARS patients. Welcome, Dr. Krakow. We're ready to hear your experience.
Thank you, Sri, and thank you, Mark, for an excellent talk. My talk is the Mode Not Taken, which describes our clinical experience dating back to 2005, when we first noticed signs and symptoms of CPAP withdrawal in our staff and in our center. It culminated in 2008 to 2010, where we actually were able to completely taper off of the use of CPAP and basically are been using advanced PAP therapy ever since. By the way, these are my disclosures, which you have on your files. Just want to point out that we are completing our study with ResMed on a randomized controlled trial of PAP for chronic insomnia, ASV versus CPAP. And I'll have a poster presentation on that at the sleep conference coming up this coming Monday. In our clinical experience, there are three main areas, issues that so much influence what goes on in terms of the way we practice sleep medicine, and again, many mental health patients with sleep apnea. The first item is that there is no definition of CPAP failure. Unfortunately, we're all influenced by these terms called adherence, compliance, and so forth, which are non-scientific. They're insurance or government regulator driven. And they actually have very little, and in most cases, nothing to do whatsoever with the concept of CPAP success or failure. CPAP failure would obviously be defined patient-centrically as something like acute or chronic persistence of patient symptoms or objective signs of poor sleep. Here's an example of a data download. We just took a random sample of a patient here, and you'll see the patient's averaging about 6 hours a night, has 100% compliance. This slide is put here to depict the fact that this has nothing whatsoever to do with CPAP failure. If this patient is still sleepy during the day, suffers from nocturia at night, still has awakenings, sleep fragmentation, nocturia, and so forth, they are a candidate for CPAP failure, which is crucial to the determination of whether somebody needs something else from the sleep center that can then be brought to the attention of the insurance company when appropriate, as needed. The second key barrier to our understanding and recognizing of CPAP failure is we don't have a definition of normal sleep breathing, meaning after an OSA or UARS patient has been treated. What is the endpoint? The American Academy of Sleep Medicine published over a decade ago the idea that you must eliminate apnea, hypopneas, and RERAs, and the RDI must be below 5 events per hour. At one point, there was even talk of doing a study on what is normal sleep breathing, what is normal sleep. To my knowledge, that has not been done. And unfortunately, this has created a very big conflict, in my opinion, or discrepancy about the way we look at the endpoint for our patients. The concept of normal sleep breathing should be a standard based on some kind of objective findings, and the findings we've chosen is what we've observed in normal sleepers who breathe normally. So, for example, back in 2003, when we opened up our sleep center, we recruited normal sleepers who breathe normally, and this is exactly the way their airflow looked. As you'll notice, this is exactly the way airflow looks on somebody who's getting a great optimal response to PAP therapy. And what we're talking about, of course, is the rounding of the inspiratory curve and the rounding of the expiratory curve. So this is the goal that we have been using for over a decade and a half that we're trying to reach in our patients when they are titrated with any PAP therapy. And what we discovered in 2003 to 2005 was how difficult it is to get to that place because of this problem. And this, of course, is flow limitation, otherwise known as UARS, otherwise known as the discrete breathing events of upper airway resistance syndrome. Now, I believe everybody knows that these are abnormal, and everybody knows that, in fact, the American Academy of Sleep Medicine, more than a decade ago, mandated that these must be treated. This is not a consensus statement. This is not a something that's optional. I mean, this is, you must treat this in a titration study. That was the rule back in 2008. And so this is the third area of confusion, because if you're not clear on how to diagnose and treat UARS, then it becomes increasingly difficult in being able to manage patients on various types of PAP therapy, particularly CPAP. I'll just say it as an aside, it still is puzzling to me that UARS remains controversial. UARS has been linked unequivocally with daytime sleepiness, insomnia, hypertension, fibromyalgia, nocturia. So anybody who has only flow limitation, or UARS, whichever word you like, and has that all night long, that is a sleep breathing disorder, whatever you want to call it, UARS, OSA, it doesn't matter. It needs to be treated. The problem, however, is how do you treat it? And here we get into the analogy that many of us, I'm sure, have used in talking with our patients, where we mentioned that OSA is a theory of a collapsible tube. When it's fully collapsed, you have an apnea. When you give it a little air from pressurized air, you now have turned the apnea into a hypopnea. Now it is a little bit more air, it's a RERA, but then you have to get to normalized air, which again, to repeat, is not just the elimination of a RERA. It is actually attempting to normalize that airflow signal. In dealing with patients, we often use our hands, showing that this is the apnea with a collapsed airway. Give it a little bit of air, we have a hypopnea. Give it a little bit more air, we have a residual flow limitation. And finally, we have an open airway, which is normalized. The problem becomes in trying to titrate out these UARS events, because amongst many patients who are anxious, and let me be very clear here, a patient who suffers from sleep apnea, although a speculative statement, by definition, must have anxiety, or almost always has anxiety, because their body and their mind have been assaulted all night long with breathing events. Any person who suffers any type of breathing disturbance will develop some degree of some degree of anxiety. And that anxiety, therefore, is likely to be very common, even in some classic sleep apnea patients. Anyway, people with known or unknown anxiety suffer discomfort, claustrophobia, panic. They may even blow off more CO2 from hyperventilation, develop central apneas. And the biggest issue then is when you talk to these individuals, and as we've mentioned, we spend a lot of time talking to mental health patients, and they frequently use these words. CPAP, in particular, feels like drowning in air. It feels traumatizing. And therefore, technically, CPAP is a traumatic stimuli. And the reason that's so important is that for a lot of patients, remember we have very low adherence in general when it comes to CPAP. And part of that reason, I believe, although it's difficult to get actual numbers on this, is because once you've used CPAP and had a traumatizing experience, you now suffer from a post-traumatic process, and you will in fact engage in classic post-traumatic avoidance behavior. And avoidance behavior means you will have attempted the CPAP briefly, maybe one night in the lab, maybe 1 week, maybe even 1 month. But the experience is so uncomfortable for you, and you rip the thing off at night, that you then not only give up on treatment in general, but the thought of using any PAP machine again may take anywhere from 1 to 2 to 5 years to resolve before a patient will begin again. When somebody is in fact fighting with PAP therapy, they end up with expiratory pressure intolerance. And in some cases, they end up developing central apneas as well. But the key here is not the central apneas. The central apneas are a tip of the iceberg. The real problem is that people who are on CPAP are fighting with positive airway pressure on expiration. And here's an example. In the bottom limb, the expiratory limb of the airflow curve, you can see this ragged or jagged edges, and these lines suggest the patient is fighting when they're trying to breathe out. And when you use advanced devices, you can make that go away. This would be central-like pauses, and this, of course, would be central apneas. But again, this is only a function. I'm only mentioning this, that this is a function of having to deal with insurance companies who believe ASV would only be used for people with central apneas. We are saying that expiratory pressure intolerance is the real key, even though we too must follow insurance guidelines on what type of device we can prescribe for someone. So the issue here is all about end expiratory pressure intolerance. Unfortunately, some training, to what extent I'm not sure, but some training is such that we focus on end of expiration in resolving apneas. But then what do we look at regarding hypopneas and flow limitation after that? I've been to many trainings where I've asked sleep technologists the question, have you been trained specifically to look at the expiratory limb of the airflow curve after eliminating apneas? And the majority of technologists tell me they are not trained to do that. And this is why it's such a big deal. We published a paper with our next speaker, Robert Thomas, about 5 years ago, describing that when you have expiratory pressure intolerance on somebody with CPAP or even somebody on another device, they will have abnormal arousal activity, excess awakenings, and they will have the failure to enter or maintain REM sleep. They'll also have excess sleep stage transitions. If you have expiratory pressure intolerance, it means you are failing to normalize the airflow curve. And in association with this, no surprise, you have patients with poor outcomes, persistent sleepiness, persisting insomnia, persistent nocturia. If you don't know, if you haven't studied the pathophysiology of nocturia, you should know that most people on PAP therapy should completely eliminate trips to the bathroom. If they don't, it is a likely reliable marker that something is suboptimal to their care. And what I'm getting at on this slide is this is how you go to an insurance company and you say, we have not been able to normalize the airflow signal. We have not been able to achieve high-quality slumber. The patient still has these residual outcomes, irrespective of how many hours per night they're using the device. So the key components, and this is a very important distinction to make compared to the great overview that Mark gave us at the outset. If you recall, he did not mention how anybody was titrated with the advanced devices in the lab. That's because in those studies they did not do it. They simply prescribed the mode and they gave it certain settings. We put our patients in the lab on the auto mode. The sleep technologist observes very carefully what's going on with expiratory pressure intolerance and with flow limitation, and is aggressively manually overriding to fine-tune both inspiratory and expiratory settings. And then there is this special focus on REM that I'll bring up. Here's the first example that looks at a patient with CPAP, BPAP, and ABPAP. Depending upon your computer speed, these may go a little bit slow or fast. We'll see. In this first slide, you'll notice that somebody is on CPAP down at the bottom. They're on a CPAP of 6. And very quickly, they're going to be switched over to bilevel because they still had a certain amount of flattening or the patient was complaining. This may have been a second opinion patient who previously had failed CPAP, but we started them in the lab. You now see them on bilevel, 10/7, and you can see there's more rounding on the inspiratory curve for this patient. And as we go along, you're going to see right about this section that they're going to be switched to auto bilevel. And this is one of the things that really sparked our curiosity which was when this switch was made, the patient went into REM sleep, the green bars. And this was a very frequent finding that made us say, why are patients going into REM sleep so quickly after being switched to auto bilevel or being switched to ASV? And the next example, we've got 4 modes that are going to be looked at. You can see we're down here with CPAP in the beginning, CPAP at 11. And this patient is doing terribly. They have flow limitation. They have expiratory pressure intolerance. They have residual breathing events. Clearly, something isn't working well for them with CPAP. Again, this may have been their first exposure, but in many cases, it represents second opinion patients we see who are failing CPAP. In just a moment, they're going to go to bilevel. And on bilevel, they went from to 1412. And you can see that the inspiratory curve is showing some better rounding, but there's still a fair amount of inconsistency in this patient. In this particular slide set, we're going to jump ahead, and now the patient is on auto bilevel. And now we have an odd finding, which is where the expiratory pressure intolerance seems to have gotten worse in some cases with the auto bilevel. There's also some central apnea, as you may have seen, but there's also still some greater stability amongst the rounding of the inspiratory curve. And now the patient is suddenly switched further on, skipping ahead to ASV, and you'll see there is greater stability in that airflow curve on the ASV. And then the final example, I think people are now familiar with Morgenthaler's concept of split therapy protocol. And here, oops, try that again. Okay, here we go. These numbers are small, but there's only a couple of changes. It starts at 15.6 over pressure supportive 3. And you can see on this auto bilevel patient, there is a fair amount of inconsistency already. There's central apneas. And you can see right here, the green bar, we're going to be approaching REM sleep. And from what I said earlier, this patient was switched on ASV before that, right here. And now we have 15.3. This is a max PS, and then min, or just the regular EPAP for ASV. And you can see there is much more consistency of the airflow signal on ASV. And this study is several years old, and that's why there is no ASV auto in this particular study with 2 EPAP settings. This is just the 1 EPAP setting. And this slide now goes on for several more seconds showing that stability. So I think I'm going to jump ahead in the interest of time. So summing up these types of titrations, we're always looking for the problem of expiratory pressure intolerance and usually more suspicion in someone with overt anxiety. Well, you can still see it in people who have covert anxiety. We often find that CPAP yields a suboptimal objective response. And keep in mind, we have had tremendous success in failing patients on CPAP in the lab. That's the nature of the split therapy protocols. If someone does not tolerate CPAP in the lab, complains about it, finds it uncomfortable, or you cannot produce a good response, you can't get them into REM sleep, that is grounds for failure that has been widely accepted by the insurance companies that we deal with. And then, of course, we switched them to these various devices, and we do look for REM, and I'll give you an example of that right now. Here's a standard hypnogram. The green bars are REM sleep. Here's a patient who was diagnosed. This is back in 2007. We were going through this transition to advanced PAP devices, and we created a metric called REM consolidation index. You'll notice that there's all these discrete fragments of REM. So we take the total amount of minutes, divide it by 22, and we say REM consolidation is only 22 minutes. Anne Germain's research group has the opposite index that they've worked on called REM fragmentation index. So this person was diagnosed, came back a couple months later for a bilevel titration. You could see they do very poorly in terms of improving the REM consolidation. There's still lots of fragmented REM, and there's central apneas at the end of the night. They come back a couple months later, again not doing well because of the central apneas. We decrease the bilevel pressures. There is a hint of some improvement in REM consolidation, but still not very much. Finally, they come back still a few months later, coming back each time because they're not doing well. They have persistent sleepiness, persistent insomnia, and they want more help. This is the first time using auto bilevel. They have 100 minutes of REM. They have 11 REM periods. We're almost up to a REM consolidation index of 10. We want to see it above 15. Finally, a year later, as we learn more and more about central apneas and ASV, this patient was on bilevel for the first hour or so of the night, was switched over to ASV, and you end up with large blocks of REM that are very much consolidated. The patient was brought back even another time 6 months later for a retitration study to fine-tune pressure settings, and you can see that the REM consolidation is maintained. Now, the remarkable thing in this patient was all these things we've talked about that we use to describe CPAP failure in our patients were present, and they were decreased once the patient went to ASV. Less arousal activity and awakenings, greater REM sleep and greater REM consolidation, a decrease in sleep stage transitions, much more comfort to the patient, and of course the decrease in central apneas. So in summary, this patient failed CPAP even through desensitization, which is another place a patient can subjectively fail CPAP and can go on to an advanced device. They had only had modest improvement in insomnia, sleepiness, and fatigue, and therefore they were a candidate for something different. Only after the patient was titrated with ASV do we see those improvements. Now, this is the summary slides. Our model is to aggressively treat the RE-RA breathing events. But to do that, we want to avoid triggering expiratory pressure intolerance so that we can get to normal breathing. And therefore, I'll leave you with this slide, which is, what if we stop looking simply at the number of breathing events? What if we flip the script? What if we start looking at the amount of time that somebody is sleeping normally, with normal sleep breathing, that is, by percentage and by minutes during the night? And if you're interested in that, all these remaining slides are something you can ponder over some night when you're trying to go to sleep rapidly. Thank you.
Thank you, Dr. Krakow, for sharing your real-world expertise.